we'll discuss about clinical features, diagnosis and management of osteoradionecrosis. In clinical features, the first and foremost important thing is the pain, right? Severe, deep, boring pain. It is deeply placed pain in the irradiated area. And the second one is trismus and swelling due to the facial cellulitis infection. Then soft tissue abscesses, draining sinuses and fistulas. Evidence of exposed bone. Exposed bone becomes yellowish. Bone looks yellowish. So exposed bone and fetid odor. Induration and ulceration of surrounding tissues. Pathological fracture. If the inferior border, lower border of the mandible is involved, it will result in pathological fracture. And other radiation effects. You know other radiation effects, radiation caries. Radiation caries especially involves cervical aspect of the tooth, especially exposed cementum, mucositis, that is oral mucosa inflammation, and xerostomia. Xerostomia will lead to the radiation caries, right? And foot lodgement. These are the clinical features. The most two important thing clinical features is the severe deep boring pain and exposed bone. Evidence of exposed bone. This is most important thing. Then coming to the diagnosis, first and foremost important thing is the history of radiation. Patient will give history of radiation to that area, and other clinical features also we should look for. Then the radiographic features. In early stages, there are no changes radiographically. The radiographs you can advise is OPG, CT or MRI scan. So early stages there is no changes, but in late stages there may be the formation of sequestrum or pathological fracture. You can see the pathological fracture in OPG. Sequestrum may form or may not form, right? Then coming to the management, basically based on these features, the two things we can do. First one is we can revascularize the bone in selected cases where it is possible. First one, revascularization of the bone or excision of the affected bone. So all the treatment options around these two factors only. We can revascularize, otherwise we can take out that bone, necrosed bone. So revascularization, non-surgical therapies aims to revascularize the bone, and the surgical therapy aims to excision of affected bone, right? In non-surgical therapy, the first and foremost we have to do is the pain elevation, because there is severe pain. So we can give narcotics or opioids or NSAIDs also in some cases. Otherwise we can give for nerve blocks, that is long-acting anesthetics like bupivacaine or alcohol may be injected as a nerve blocks to relieve the pain. And the second one is antibiotic therapy, right? If there is infection, then we should give the antibiotic therapy. Again the same thing, same as the osteomyelitis. We can go for penicillin plus metronidazole, or we can use the clindamycin alone. This is the antibiotic therapy. If there is infection, then we must go for antibiotic therapy. Then local wound debridement and packing. Local wound debridement with the antibiotics or normal saline, and we should pack that area. Exposed bone is packed with a gauze containing neomycin, that is one of the antibiotic, and zinc oxide eugenol. Zinc oxide eugenol acts as a optandate, that is pain relieving agent, and neomycin acts as a antibiotic agent. So with these two agents, pack is placed, and this pack should be repeated every week until there is bone healing and covering, right? Covering of the exposed bone. So this is local wound debridement and packing. And most important thing is we can go for HBO, hyperbaric oxygen therapy. We will make a separate video on that. This aims to, what are the 3H principles? Hypocellular, hypovascular and hypoxia. So these This HBO aims to improve those 3H. That is the basic thing. Then ultrasound therapy. Ultrasound therapy may also provide neovascularity, that is new blood supply, new blood vessel formation or new cells formation. So ultrasound therapy can also be given. This should be combined with the intraoral debridement. That means we should debride the wound and go for the ultrasound therapy. Then nutrition and diet, that is diet rich in vitamins and protein should be given. This is one of the supportive measure. So these all are non-surgical modalities. Then coming to the surgical therapy, the sequestrectomy. When there is non-healing bone that is exposed intraorally, so we can go for sequestrectomy. This is same as we explained in osteomyelitis management. Then bone resection. If the bone disease osteoidonecrosis is much more wider, then you can go for bone resection. That is non-healing cases, you can go for bone resection. Right? We see bone resection procedure, how we should do it. Bone resection can be done intraorally or extraorally, in local anesthesia or general anesthesia. But the intraoral approach is preferred because the skin and vascular damage is already there due to the radiation. So intraoral approach is more generally recommended. Then you can see this is the mandibular ridge and this is the tongue. So in intraoral approach, we have to take the incision along the alveolar crest like this. This is the incision. And after taking this incision, you have to reflect the flap. You can see in this diagram. These red lines are nothing but this red one is the labial flap reflected and this is the lingual flap reflected, and you can see the bone. This is the bone and this blue color one is the osteonecrosed bone. After that, we have to take a micromotor and start doing holes in the cortical bone until you will get the bleeding. That means that is the way to differentiate between the necrosed and the vital bone. So you have to get the lines where you have to place the osteotomic cuts. By doing this procedure, you can differentiate between the necrosed and the vital bone. Right? After doing that, that is after making perforations and differentiating between the necrosed bone area, then you have to place the incision cuts in the bone. That cut may be done with the micromotor, or you can use the Gigli saw also, that is rotating saw. Okay, and rotating saw also can be used, and Gigli saw is also can be used with the hands. So you can see in this diagram, this is the buccal flap and this is the lingual flap, and this is one side bone fragment and another side bone fragment. In between this area of bone is removed. So after removal, you should make sure that there is no sharp bony ridges, and we have to close both the flap margins, that is labial one and lingual one. You have to close that. Okay, and again the same thing, you have to place the sutures along the ridge like this. After closing labial and lingual flaps, you have to place the sutures. This is the intraoral approach, which is preferable. But in some cases, when the bone necrosis is extensive, you can't go for intraoral and you have to go for extraoral approach also. In extraoral approach, the submandibular approach is preferred one. That is taking incision in the submandibular region 1 centimeter below and parallel to the lower part of the mandible. That means you have to take the incision like this, submandibular incision. After that, you have to elevate and you have to delineate the landmark, the area of the bone necrosed. And after that, you have to make the incision. Now in this case, this blue line is the osteonecrosed bone. So you can place the incision here and you can place incision bone cut along the ramus. These are the bone cuts. Right? Some amount of the normal bone should also be included. And if the extensive osteoarthritis is there, then you can go for the complete disarticulation of the mandible also. This is the extraoral approach, right? This way you can go for resection, and a proper closure should be provided. And we'll see now the prevention. What we need to do in irradiated area to prevent the osteoradionecrosis. The first and foremost is extractions. That means before going for radiation therapy, all teeth in the line of radiation should be extracted, whether good or bad, no matter. All the teeth in radiation line should be extracted pre-operatively, pre-radiation. After extraction, approximately you have to wait for 10 days, then you can go for radiation therapy. Right? And another point is carious teeth or non-vital teeth or periodontally involved teeth in other, that is maxillary arch, another side of the mandible. Right? So all the teeth in line of radiation should be extracted, good or bad. In other area, that is teeth in not in the line of radiation, in those cases you have to go for extraction of carious, non-vital or periodontally involved teeth. Right? And after extraction, you have to place sutures instead of leaving the wound to heal like that only by secondary intention. You have to provide the primary closure, and you should make sure that there is no sharp alveolar ridge or sharp bony spicules. And we have to maintain the good oral hygiene also. Pre-operatively and post-operative also, you should instruct the patient to maintain the proper oral hygiene. And fluoride therapy can also be given, topical fluoride therapy can also be given to prevent the radiation caries. And after radiotherapy, if you want to go for extraction, that means after radiation, if you want to go for extraction, in those cases the extraction should be done as much as atraumatic as possible. As much atraumatic as possible. Preferably you should avoid the extractions. You should avoid any dental extractions in a heavily irradiated jaw. But if there is the case where you have to do the extraction, in those cases extractions must be as much atraumatic as possible. And the recent developed thing is giving a medical regimen before the extraction in irradiated cases. That medical regimen includes pentaxiphyllin plus tocopherol plus or minus clodronate. Right? If there is extraction in irradiated jaw region, we have to do the extraction. Then 1 month before the extraction, you should prescribe the patient to use pentaxiphyllin 400 mg twice daily and tocopherol, nothing but vitamin E, 1000 units per day. Okay, this is the basic regimen. This should be prescribed 1 month before the procedure and until the wound healing. In some cases, clodronate is also included. This therapy is based on the recent etiopathogenesis theory, that is radiation-induced fibroatrophic theory. One theory is there. According to that theory, radiation-induced fibrosis and the osteoradionecrosis, the changes in the osteoradionecrosis are due to the effects of free radicals, that is oxidants. That theory says like that. It is due to the free radicals, oxygen free radicals, plus due to the radiation-induced fibrosis. So according to that theory, this drug regimen works. Pentaxiphyllin is an antioxidant and it promotes the blood to freely circulate within this thrombosed vessels or narrowed vessels. Right? It promotes the blood circulation freely in the narrowed vessels, and it is a vasodilator and it inhibits the fibroblast proliferation, thereby acting as an anti-fibrous regimen. So basically this regimen is antioxidant plus anti-fibrotic therapy to prevent the osteoradionecrosis. And chlordronate is a bisphosphonate which is used to reduce the bone necrosis. It is used in the case of bisphosphonates are used in the cases of osteoporosis or osteonecrosis, like in those cases. It inhibits the osteoclast, thereby reducing the bone resorption. Right? In some cases, chlordronate is also used. This is not a standard thing, but the recent advancement is this. So if you want to go for extraction in a irradiated jaw, in order to prevent the osteoradionecrosis post-operatively, we are going to give this drug regimen 1 month before the procedure and after the procedure until the wound healing occurs. So this is all about osteoradionecrosis. If you like this video, hit the like button, share the video, subscribe the channel.